Okay, I think we're ready to get started. Well, on behalf of the Center's director, Professor Sneed, and the entire Center staff, let me welcome you to the 31st Annual Medical Ethics Conference. This is always a wonderful joy for Center to be able to provide this program for all of you. We like to see you again, so welcome. It's always wonderful to see so many familiar faces and a few new ones as well. For those of you who may not be that familiar with the Center, all of our work at the Center is directed towards sharing the richness of the Catholic moral and intellectual tradition through teaching, research, and dialogue across a range of disciplines and at the highest level. And let me just mention that this, all of you who are familiar with this medical ethics conference are aware that David Solomon, of course, has been the heart and soul of it for very many years. And David has, for those of you who may not know, recently announced his retirement. So this is his last year. And I would say that David has done tremendous work here at Notre Dame. The Center would not exist without him. And without the Center, the university would not be what it is today. And so I think that we should all thank David for his wonderful work in setting such a wonderful foundation for so many good activities and creating such a great community. And he was a blessing to Notre Dame, and it's sad to have to see him leave. But please join me in thanking David for all of his work. And as David reminded me, we should be looking to the forward, to the future and not just the past. And our vision at the Center is inspiring for us, and I think for many people here at the community. And again, that is largely thanks to the work that David has done in setting up the Center. And we are very hopeful that we are making a real difference here. And we're very excited about the future. We are continuing to expand. We've been very successful. Carter has carried the torch valiantly and continues to press forward. So we are very hopeful about the future. So let's, in the interest of time, move on. Slide. I have to show you a slide. There it is. Can I go back now? Look at it. Escape. No? Is that good? Okay. So our first speaker, no? What? Is that okay? Okay. Our first speaker is Dr. Lauris Kaldjian. Dr. Kaldjian directs the program in bioethics and humanities at the University of Iowa Carver College of Medicine, where he is also a professor in the Department of Internal Medicine and holds the Richard M. Kaplan Chair in Biomedical Ethics and Medical Humanities. He received his medical degree from the University of Michigan, a doctoral degree from Yale University in religious ethics, and completed his residency and fellowship training at Yale in internal medicine and infectious diseases. Dr. Kaldjian's research has focused on ethical issues in end-of-life care, disclosure of medical errors, ethics education, and the role of philosophical and religious beliefs in clinical decision-making. From 2008 to 2010, his work was funded by the John Templeton Foundation, which led to the publication of Practicing Medicine and Ethics, Integrating Wisdom, Conscience, and Goals of Care, which was published by Cambridge University Press. This book includes a framework for practical wisdom in medicine that reflects the importance of integrity, moral dialogue, humility, and professionals' obligations to patients themselves and society. The title of Dr. Kaldjian's presentation today is, Should Physicians Inform Patients About the Cost of Expensive Treatments as Part of Shared Decision-Making? Please join me in welcoming Dr. Kaldjian.
Yep, all set, thank you. Thank you, Ryan, and thank you, Carter and Laura, and also thank you, David, for years ago allowing me to walk into your office relatively unannounced and to be received so warmly and basically to be allowed entry into this profoundly important community for me over the years. So it's another great blessing to be here. I'm going to try to stay friends with the clock on the wall so that we can get to our discussions and our homegrown expertise on this question that I'd like to address today regarding costs, and specifically costs and how they should or shouldn't be part of what we're literally doing with our patients in terms of communication in real time. The kinds of costs that I have in mind are, for instance, these. They range from small to very large. SIBO stands for small intestinal bacterial overgrowth, if you weren't aware of that. And recently I've had some of my primary care general medicine patients with this condition, and I've had to discuss and have discussed with them whether they'd like to pay $600 or $10 for the antibiotic. And the latter drug is incrementally a bit more effective, according to one study. Needless to say, both of the patients I've recently discussed this with have opted for the $10 version. Likewise, you can see a case that I once upon a time heard about regarding an implantable cardiac defibrillator in a patient with recurrent ventricular arrest, i.e. sudden death, in a 60-year-old woman with metastatic cancer and a prognosis of 6 months. Needless to say, the cardiologist was wondering about the appropriate response to this woman's request for that expensive device in those circumstances. I know of another situation once upon a time of a young man who needed a bone marrow transplant costing at that time around $100,000, and the hospital was not in a position to be able to do that because this patient had no legal standing in this country and no financial resources. And then I also once upon a time heard of a situation of a young man who was in relatively good health until having a cardiac catheterization that had complications associated with it, such that he developed refractory heart failure and was given one of these left ventricular assist devices and eventually had a total artificial heart in place, both ventricles. And after an arduous 6-month course, finally died. And afterward, the cost was $2 to $3 million. Of course, no one knew before his death what that outcome would look like when they were hoping for transplantation. But this is just the sort of thing that people in medicine have to deal with. And let me also add that I realize for the clinicians in the room, that each of us have different sort of financial circumstances in terms of the kind of medicine we practice, primary care versus specialty, non-procedural based versus procedural based. And I also am aware of the fact that for some of us, we don't have to have these discussions as often. Others, I get the impression based on data, are not infrequently having these discussions. And some of these discussions are being had in other ways, right? The patients who I see because the front office has allowed me to see them. So someone's already done, shall we say, the wallet biopsy, as some have put it. Okay. Forgive the simplicity of this slide, but it's just to remind us that there's a lot happening in terms of what we give and what patients receive and what we in return receive from them regarding the practice of healthcare and the receiving of reimbursement. So you can imagine just the sort of poor artwork gives you the impression of different ways that these transactions can occur. But getting to the bottom part of this slide to say that I think that there are deep tensions as just background concerns for this whole discussion that have to do with the contrast, say, between care and transaction, medical needs versus financial interests, practices versus institutions. Those of you who know Alistair McIntyre's work, I think we've all been helped by his insights into how the pure practice, say, of medicine or the pure practice of music for a violinist is something unto itself that has its own intrinsic sort of framework and in certain senses, morality. By contrast, institutions have to exist to support those practices. And I think he very soberly but helpfully reminds us that those tensions will always exist. We cannot practice medicine without the institutions, and the institutions couldn't have the delivery of what they want to put forward to people like patients without us practicing it. Another really useful piece related to this, I would suggest to you, is this piece by Al Johnson called Watching the Doctor, written some years ago. And he very nicely comes up with this phrase, the moral archaeology of medicine. And he traces it back historically to the Greeks and the medieval Christians in monasteries, the charitable tradition of Judeo-Christian healthcare. And he very artfully describes a story that basically says, since the medieval times, there have been these two strands within the profession, in competition, in tension, and his take on it is that they will always be there. And I think there's something helpful about getting these kinds of assumptions or observations out to begin with. So as everyone says, healthcare costs are too high, and you can see the kinds of causes listed there that are usually mentioned, at least as being part of the story. And of course, consequences can be far-reaching, but for the purposes of today's talk, I'd like us to be thinking about consequences for individual patients versus consequences for society. And of course, I realize those two are connected, right? And yet at the same time, there's a certain artifice that I need to use to play out the contrast, not because there's an absolute partition between individuals and communities or individuals and groups, but because in our role, those of us who are clinicians, we don't treat groups, we treat individuals one at a time in a basic sense. And yet other entities in society, of course, have to be very, very mindful of groups. So part of the upshot of my comments today will be to say that we need to be focusing on two different domains and realize that different people have to be devoted to different concerns. I'm not going to talk about the challenge of determining costs. This is a nice piece that showed us how difficult it is to figure out what something really genuinely costs in this world of healthcare. I apologize for the small type, and I'm happy to share these slides with anyone who'd like to get these kinds of references. I also won't talk about the challenge of controlling costs. There's this fancy new pharmaceutical called Gleevec to treat chronic myeloid leukemia, and it turns market economics on its head, apparently, by showing that even when the same company introduces a competitor drug, the original agent climbs up in its cost and becomes more expensive rather than less. So I leave that to your imagination to understand why these kinds of curious things happen when there's a lot of money to be made. Some basic background assumptions and claims. I do believe, whatever else you hear me say today, that resources should be used cost effectively. Okay, so it's one thing to talk about the need to control costs and to ask physicians to do more than what they usually have been understood to do. It's another thing to not want to deny that we have to be sensible and not waste things when we have good choices to make. Also, that resources are actually or potentially limited, and even resources as basic as your time and my time with patients. So various ways to look at that. And also this notion of opportunity costs is also something that's real, to say that if we devote resources to one place, those resources are not available in another. I actually think that's part of the problem for physicians, is that when we believe we're being asked to save costs so that the whole system can benefit, we don't get usually the privilege of seeing the benefit of cost being saved here and being applied there. In the same way you might say in a household economy, when one of your children is asked to forbear and go without something so that another of your children can benefit from that resource because for whatever loving reason they're a higher priority for the moment. Needs should be distinguished from wants. I think each of us as clinicians can think of experiences where we would want to make that kind of distinction, challenging as it may be at times. And then, of course, the tension between individualism and community in our society is something that we take seriously. So I'd like to be focusing in general on the contrast between what I would call patient-centered reasons for wanting to be straightforward about costs and society-centered. One example here of a patient-centered concern, it's one of the articles that's included in your conference packet today. And this is a very short, provocative, somewhat punchy piece that doesn't go into a lot of details, but it does suggest that we should try to help avoid financial harm in our patients in the same way that we try to avoid hospital-based infections. I think I'll leave it to you to decide whether you think that's a valid analogy at the end of the day, but they make recommendations, and they make four. The first, to screen to assess for financial risk and preferences they're recommending for every patient. And thereby they're wanting to use the notion of universal precautions, suggesting that since you don't have a way to profile someone in advance, you need to ask and inquire with everyone to find out whether they're at financial risk. And they also believe that physicians should take responsibility for knowing the financial ramifications of the care plan. So as if you didn't think you had enough to do at this point in your careers, now you need to look after that as well. And then to optimize personal care plans based on the patient's coverage or lack thereof. And then their key phrase here, they say, to provide truly patient-centered care, physicians can live up to the mantra of first do no harm by not only caring for their patient's health, but also for their financial well-being. I was reminded of one of Paul Ramsey's critiques of the WHO definition of health as a state of complete physical, mental, and social well-being. I suspect if Paul Ramsey were here, he would find this comment about our need to look after our patients' financial well-being as one more example of, shall we say, an aggrandizing approach to the definition of health. So we can be critical in certain ways of this sort of a commentary, perhaps, but at the same time, I was interested to come across a study from the Kaiser Family Foundation that surveyed a group of respondents regarding their medical bills. And the take-home message was that 26% of U.S. adults say they or someone in their household had problems paying or an inability to pay medical bills in the last 12 months. And you can see then the sub-data on different groups. We're not surprised that the uninsured had more of a problem, but notice that plenty of people with different forms of insurance also have had such problems. I think for some of us in our practice of medicine, we may not have had windows into these realities the way others have had, and I think this needs to be taken seriously. I realize the print is very small here, but it was sobering to read the kinds of steps that people have to take in order to try to pay their bills. And so this has caused me to wonder, I wonder how many of the patients I've cared for and have recommended various treatment plans, even as a primary care physician, where I may have had no idea what was really going on financially behind the scenes. They also asked the people in this study, basically, how often have your doctors talked to you about the costs? And you can see that, in most cases, doctors are not talking, at least to this patient sample, about costs. So that is just a way of raising and pressing the question of, should we be doing this, and if so, how? By contrast, an example of what I would call a society-centered concern. And this also is included in your course packet. And the title of this paper is ACOs and High-Cost Patients. And they point out that, based on their data in this study, that the costliest 1% of patients account for 15 to 20% of overall spending. And then at the bottom there, they write, high-risk care management. It directs additional resources and services toward patients who are likely to incur high costs and experience poor outcomes, and that doing this kind of management could substantially reduce costs and improve quality. I don't know what your take is on these kinds of articles, but I see the emphasis, even as expressed in the title of the article, much more on cost reduction rather than quality enhancement. And I wonder, why wasn't this article entitled ACOs and High Complexity Patients or ACOs and High Need Patients? Emphasis on cost. And that brings us to population health. I expect the clinicians in the room have heard this phrase used. And when you read articles that go back to when this phrase first popped up, I believe it was in the 1970s, it basically says that it's the desire to enhance the integration between patient care and public health, merged as population health, with three interrelated aims. So to improve the care of individual patients, improve the health of populations, and key to reduce per capita costs. And when I see reference to population health from administrative quarters, I confess I tend to see it mostly as emphasizing the need to reduce costs. Though I understand even access to care, standardization of care, there are a lot of good quality reasons for why people care about population health too. I'm trying to diminish that. But what's happening, I think, in this is that there becomes what I would call a bifocal perspective that increasingly is asking clinicians as frontline care providers to actually wear two hats. And one of my basic questions is that reasonable and feasible to do? So two questions about this. In response to this idea of wearing two hats, I would ask, does each physician owe undivided advocacy to each patient? Not independent of, not oblivious to, but independent of cost in a basic way. This notion of advocacy, I think those of you who are lawyers in the room, I think have had ingrained in you more of a sense of client advocacy, perhaps than clinicians have had of patient advocacy. And it's the idea is to say that even though it seems artificial in one sense is, we pretend, as it were, that this is my only patient in the universe when this is the patient I am with. Those of you who work in emergency rooms and have 5 car accident victims to deal with right now obviously have a different situation. The second question is, does undivided advocacy, if you believe it's plausible and morally legitimate, invite or discourage the discussion of costs as part of shared decision-making? So in terms of shared decision-making, what are the dimensions? This is the way I configure it when I teach about these things. So the goals, probabilities, and treatment burdens, these are the things we talk about. When you're, say, discussing with a patient who has prostate cancer, what form of treatment would be best for you, sir? But another dimension, which I mention only to set aside usually, but today I actually bring to front and center because of the topic of this talk, is to say, should cost be part of this multidimensional dialogue with patients? And then the question would be, if cost is to be entered into this discussion, for whose good? Is it for the patient's good or some other patient's good, some other population's good? And I want to raise here the question, when talking about for whose good is this, the question of injustice and the possibility of it. So if you were to take the position that you think physicians should be playing both of these roles and discussing costs with patients and trying to control them on behalf of the population, do you think that I or other physicians and surgeons in this room can do that without showing favoritism? I won't answer that question now. I know my own answer about that. But I would think that we need to be honest about this question because it raises fundamental questions about moral anthropology. And I believe moral anthropology must include a serious sense of our fallibility as human beings. I certainly say that as a Christian with an understanding of what human sinfulness is. But I think one doesn't even have to be, that as G.K. Chesterton once said, you know, what's the problem with the world? I am, was his answer, right? So one can come from various perspectives to realize and to be able to say that we have a capacity for injustice. And I think this cautions against any optimistic proposals for physicians as population health managers and cost controllers. And I would also want to raise the question, for those of us especially who are involved in education and training of younger professionals, as we see what could be called an ethic of cost control that is becoming more prevalent, what are the odds that that will or will not have an impact on how younger clinicians see their duty regarding discussions of and controlling of cost? And could it be that with a general economic imperative to control costs, do we expect that the application of that imperative is going to be so-called evidence-based and just? Or might we anticipate that there will be irregularities due to biases, discrimination, et cetera? And when you think about the way clinicians communicate with patients, sometimes you as a clinician might choose to withhold information, hopefully for good reasons, but sometimes it might be questionable. Other times, usually you inform, sometimes you recommend, sometimes you attempt to persuade a patient toward what you think is best for them. When you think about how morally dynamic these dialogues are, we need to ask ourselves, to what extent is that dynamic susceptible to injustice based on what we know about human beings and our nature? So some might say, okay, so at risk of injustice, I grant you this is a fallen world. But isn't it also unjust to perpetuate an economically unsustainable healthcare system? Don't we have to admit that there are two good sides to this debate? So just because the needs of individual patients ought to be protected does not mean there aren't principled reasons to concern ourselves with the needs of society. I take the point of that remark. And this actually, speaking of principled reasons, it reminds me of principles, a few in particular. I think even our common use of the principles of beneficence, utility, and justice, actually, even though we don't often hear it put this way, capture what it is that concerns us here in the tensions. So one way, if you read, William Frankena's textbook on ethics, he has a wonderful treatment of the contrast between beneficence and utility, and how what my way of putting it would be to say that in one way of saying this is that utility is maximizing beneficence across a group, right? Because in the principle of beneficence, there's nothing intrinsic in the way it's usually presented that talks about any maximization. That you get from a principle of utility. And I think that this is part of the tension between beneficence and utility in the way we think about this. But likewise, if you read, for instance, Pieper, on his notion of the virtue of justice, he talks about three different forms, two of which I've mentioned here, commutative and distributive. I think that contrast is also getting at the contrasts that we're talking about here today, the individual versus the many. And so our usual approach as frontline clinicians is to want to give to each according to their need, right here, right now. But a distributive notion of justice, of course, by definition, takes into consideration the many, not just the one. So I think these can at least help us articulate, if not resolve, some of the concerns that we have. Another observation to make along the way is to say that, and after all, we do in fact at times expect something from our patients themselves regarding other persons. So in the cases of infectious disease, we don't tolerate, sometimes in extreme forms, say if somebody has tuberculosis, pulmonary tuberculosis, we would not allow them to walk freely down the street spewing tubercle bacilli willy-nilly and allowing you to inhale them. Even in organ transplantation, when you talk to people in that field, they talk about the need to be a good steward of the organ you've been given, on the understanding that you have received something that someone else has not. You should therefore care well for it. But even take end-of-life care, and from the ethical and religious directives that some of you know far better than I do, number 57, disproportionate can mean not to impose excessive expense on the family or the community. Very powerfully stated, but notice in the color I put, in the patient's judgment. And that's, of course, part of hopefully what we'll be talking about in our discussions today about this. So my answer to the question that is the topic of this presentation would be, it depends on the purpose. And so we have these two domains, patient-centered possibilities and society-centered, and you can see them listed there. You can think about allowing informed decisions about how patients want to spend their own money, encourage them to avoid financial harm if they don't realize what's about to happen, and possibly even to increase their appreciation for the value of a service. I once worked in a mission hospital where they charged, and I was there just for a short time, they charged a nominal fee for prescriptions. Because if they didn't, it was more likely that at the exit of the clinic, you would see the medications on the ground. Because patients were actually, didn't have the courage to tell you, but they weren't planning to take what you were prescribing. But if you charge some money, some more buy, and we do that in our system too in various ways. Society-centered, you can see the reasons given there. And that last one is one that is very much on my mind to wonder about, would there be any circumstances under which one could imagine helping patients basically be more other-regarding? I'm not recommending that as such right now. I'm just putting that question forward because I think that there are certainly some clinicians I speak with when they're wondering about even what they might consider the indecency of one person consuming so much care when other people are in such need. And so this idea of being other-regarding, but whose role, if that should ever be articulated to somebody, especially during their moment of medical need, whose role should that be? So it also depends upon the details. If you do take the position that patients should be informed about the costs of their own care, which patients, all of them or certain groups, and which services, and when, before, during, or after care. One of the cases for discussion today involves very much real time. And then to me, one of the biggest questions would be by whom? Physicians, nurse, social worker, chaplain, discharge planner, business office, or the ever-convenient iPad, right? Let the iPad do it. Because then we don't have to actually have that eye-to-eye moment where we're talking about things that some of us would rather not have to talk about. So just about done here. So approaching an answer, I would want to suggest at least four sort of things to say here at the end. One is that role fidelity. It's a notion that I like to use to capture the sense that we have to be clear on our priorities as clinicians. And I would say that it needs to be the patient, not the patient, population as being the focus of our concern. Not because we don't care about populations, but because our role at that moment is not the population. It's to wear that one hat at a time, not two at a time. And then representative advocacy and division of labor. It's intentionally that I'm sort of picking up on the notions of even representative democracy, this idea that each should have a representative to represent their needs. That doesn't mean that every patient will get what they want or even what they need. It may mean that other entities or structures have to make those difficult decisions that allow justice, distributive justice, to happen more broadly over a population. But what it does mean is that every individual will at least have one person on their side of those discussions. And then I would also want to say that I think there will always be irresolvable tensions between individuals and populations and between individuals and institutions like hospitals when these kinds of questions come up. So I think patient-centered cost information may be very important and relevant to patients, and some of us who tend not to talk about these things probably need to be encouraged to think about when we should do that, and if so, how. But somehow, as we operationalize that, we need to be sure that our patient is perceiving us doing that for their benefit, not for mine, not for somebody else's. And I'm not so sure that in advance one can come up with a plan that would accomplish that. In the times when I've discussed costs with patients, it's emerged in such, shall we say, an organic way that I don't think there was any doubt on the part of the patient, because I was actually holding out options and saying, I realize that's a lot of money. I'm not sure you want to pay it. Do you want to pay that? And so there would be less room for misunderstanding. But the more routinized these things become, I think the more reason there could be reason for suspicion. Society-centered cost information, I think, will always risk undermining trust. Trust not in the sense of even the fairness of the system as such, but in the concern of the clinician. Whose side is this clinician on? Is this clinician really talking on the part of someone else or on my part? And so I would end by saying this is an important job, this idea of society-wide cost information for society's interest, but it belongs to someone else. So without further ado, I think we can move on then. Anything else to say?